بسم الله الرحمن الرحيم. نبدأ محاضرتنا اليوم في محاضرة الأورال سيرجري في موضوع هو very important the endocrine system. عندنا شرحنا في المحاضرة السابقة على suprarenal gland. We can continue with other gland, the thyroid gland. We discuss with you thyroid diseases and dental management. Introduction to a simple word about the anatomy and physiology of thyroid gland. The thyroid gland is located in the anterior part of the neck. It is anterior to the trachea beneath the larynx. Its location in neck just below the larynx is two loops, each about 5 cm 2 inch in diameter long, are positioned on either lateral side of the trachea and connected anteriorly by a bridge of tissue called isthmus. This figure shows the location of thyroid gland anterior to the trachea, below to the larynx. The thyroid is the largest of endocrine glands. Its weighing between 22 and 25 grams. This view from posterior view, and we can see its concavities that have accommodate the trachea. And we have within the thyroid gland 4 glands, 2 pairs of parathyroid gland that it is location within the thyroid gland matter. The size of thyroid gland. The thyroid gland weight is 10 to 20 grams in normal adult. Thyroid volume measured by ultrasonography is slightly greater in men than in women. It increases with age and body weight. It decreases with increasing iodine intake. The thyroid is one of the most vascular organs in the body. Thus, ultrasound measurement of thyroid volume and even nodule size can differ markedly from the size after the devascularization and resection. It receives an abundant blood supply between 80 to 120 ml per minute. So the blood supply of the thyroid gland through these arteries. They are paired of superior thyroid branch of the external carotid artery and the paired inferior thyroid branch of the subclavian artery. We have the blood supply from two sources, from external carotid artery and from subclavian artery. So the anastomosis between these two arteries through the superior thyroid branch and inferior thyroid branch, and have the right and left one. The venous drainage. The venous return is through the paired superior and middle and thyroid vein that pass into the internal jugular vein, and through inferior thyroid vein that empty into brachiocephalic veins. حقيقة الدرينج venous drainage ليس 2 vein ولكن 3 vein, superior, middle, and inferior thyroid vein. The superior and middle thyroid vein drainage to the internal jugular vein, and the inferior thyroid vein drainage directly to brachiocephalic vein. The lymphatic drainage of thyroid gland. The lymphatic vessel of thyroid gland drain into pretracheal lymph node and paratracheal lymph node. The effluent of this node drain into the deep cervical lymph node. حقيقة خلال two group of lymph node, pre and paratracheal lymph node were drainage, and these two lymph node drain to the deep cervical lymph node. The thyroid is innervated by both ganglionic neuron from the superior and middle cervical sympathetic ganglion, and preganglionic neuron from ganglia derived from second through the seventh thoracic segment of the spinal cord. So, it's sympathetic innervation from the middle cervical sympathetic ganglion. Parasympathetic derived from the vagus nerve, the 10th cranial nerve, its right and left superior laryngeal nerve, and auricular laryngeal nerve. This nerve that is as a parasympathetic innervation of the thyroid gland. The physiology of thyroid gland. The thyroid physiology is of there are hormones that secrete from the thyroid gland. trapping of inorganic iodine from the blood, oxidation of iodide to iodine, binding of iodine with tyrosine to form iodotyrosine, coupling of monoiodotyrosine and diiodotyrosine to form T3 T4. وظيفة الثايرويد gland هي من خلال this function trapping, oxidation, binding and coupling. The thyroid hormones stored as iodide-rich thyroid colloid are two hormones, thyroxine and triiodothyroxine. Thyroxine is called T4 or tetraiodothyroxine, mainly which has half-life of 1 week and is converted to triiodothyronine, T3, a small amount only, the active form which has a half-life of 1 day. إذن T4 الهالف لايف مالته لمدة أسبوع ويتحول إلى T3 ولكن T3 هالف لايف فقط يوم واحد. How control the thyroid secretion? The thyroid gland release thyroid hormone is under the influence of thyroid stimulating hormone TSH or call it thyrotropin from a pituitary gland, which is self-regulated by thyrotropin releasing hormone TRH from hypothalamus. So it's regulation like suprarenal gland that have the TRH from hypothalamus that secrete this hormone to stimulate pituitary gland to secrete TSH or that is go to the thyroid gland to stimulate the thyroid gland to secrete T3 and T4. The thyroid hormone feeds back to the hypothalamus and pituitary to regulate TSH release. حقيقة, that is negative feedback mechanism. So, by the hypothalamus that secretes TRH that stimulate the pituitary gland to secrete TSH that stimulate the thyroid gland to secrete T3 T4. So, when the concentration of T3 T4 is very high, the suppression of the hypothalamus to secrete TRH, so no secretion of TRH, so no any stimulation to pituitary gland to secrete TSH, so no any TSH, so suppress the thyroid gland to secrete T3 and T4 and to continue the cycle. The regulation of thyroid hormone production by negative feedback mechanism and is by TRH, TSH. So the T3 and T4 that go and congested of T3, T4 in the liver, and this is that have increased secretion concentration of T3, T4 congested, such that the suppression of TRH and this lead to suppression of TSH. So the secretion of T3, T4 is reduced by this circle. The action of thyroid hormone. Thyroid hormone act on metabolism by regulation, protein synthesis via effect on gene transcription and RNA stabilization. They have profound effect on sensitivity of tissue to catecholamine, mitochondrial oxidative activity, synthesis and degeneration of protein, differentiation of muscle fibers, capillaries growth, level of antioxidant compound. How we can examine the thyroid gland laboratory by thyroid function test include the following. We have a level of free T4 and free T3 in serum provide a better assessment of thyroid status than do total T4 and T3. About 95% of thyroid hormone are bound to plasma protein, especially thyroid binding globin, call it TPG, and thyroid binding prealbumin, call it TBPA. Second investigation, thyroid stimulating hormone TSH level can be assessed, and we do thyroid antibody test. And radiographically, by doing ultrasound and radio iodine uptake using 1030, 111, and 131 I and 123 I are other common investigation for thyroid gland. This figure shows how can examine by ultrasound. Use high-frequency sound wave to make a picture of thyroid gland by ultrasound. This figure uses a radioactive substance that have hot and cold that mean the scanning of thyroid gland and its function. Now we start with the subabnormality and disease within thyroid gland. We start with the lingual thyroid. The thyroid normally develops as a downgrowth from the foramen cecum at the junction of posterior third with anterior two-thirds of the tongue. As you see this figure, this is the thyroid, lingual thyroid within the dorsal surface of the tongue, between the anterior two-thirds and posterior third of the tongue. Rarely, ectopic thyroid tissue remain in this tract and may be seen as a lump anywhere in the midline between the foramen cecum and epiglottis, but has also been recorded in the oropharynx, infrahyoid region, larynx, esophagus, heart, and mediastinum. We can see this ectopic lump within the course of its migration of thyroid gland from the foramen cecum to its position anterior to the trachea below the larynx. And sometimes we can see it in another position of the body, like the oropharynx, infrahyoid, larynx, esophagus, and heart and mediastinum. The lingual thyroid is seen mainly in females and is often asymptomatic, but may cause dysphagia, airway obstruction, or even hemorrhage. حقيقة هي فقط انتفاخ يكون في منطقة اللسان. هذه لا تأثر، بس في حال إنه هذا السوالينج يكبر، lump يكون very large that lead to stop breathing, airway obstruction, or difficulty in swallowing, or there are irritation and lead to hemorrhage. Hypothyroidism may be associated in about 1/3 of cases, and occasionally the lingual thyroid become malignant. There is a rise incidence of thyroid disease in relative. حقيقة يتعلق thyroid gland هو بالdiseases that affect of thyroid gland، وأكثر الأحيان بكون malignant condition. Lingual thyroid may not be suspected until the lump in tongue has been biopsied or excised and examined histologically. حقيقة صعوبة البلع راح تؤدي المريض إن راجع إلى الطبيب، فعندما يعمل بايبسي أو عند رفعها بشكل كامل إذا كانت صغيرة راح تنعرف أنه lingual thyroid. The diagnosis can be confirmed by iodine 123 or 131 or technetium-19 uptake in the tongue, or biopsy by CT scanning without contrast, or by MRI. حقيقة فحصك very simple. إذا أردنا نتأكد أنه هي thyroid gland، أما بالradioactive substance or take biopsy or by CT scanning. Treatment depends on the size of lingual thyroid, but thyroxine may be needed, and if the lump does not regress sufficiently, the lingual thyroid can be ablated based by surgery if the patient unfit by iodine 131 if normal functioning thyroid tissue is identified in the neck. حقيقة أما تعالج بالثايروكسين هرمون أو by surgical operation أو by radioactive substance. Second condition is called goiter. هذا الشيء العام في enlargement of thyroid gland. A goiter is an enlarged thyroid gland, usually a consequence of hyperplasia secondary to excessive TSH level caused by low circulating thyroid hormone. Most goiter are acquired and seen in Graves' disease or thyroiditis, but a few are congenital and seen in retinism. Thyroid cancer is another possible cause that lead to enlarged thyroid gland. Thyroid function is assessed to determine whether it is normal thyroid or hyperactivity, hyperthyroid, or hypoactivity, like hypothyroid. The hypothyroidism, the thyroid gland can be small or large goiter. depend on the causes of low level of thyroid hormone. Most goiter do not require surgery, but it is indicated if there is a danger of airway obstruction, or that may be cough, voice change, dyspnea, tracheal deviation, or dysphagia, or for cosmetic reasons. Dental management in goiter may be influenced by abnormal thyroid function, by underlying causes of goiter, or by complications such as respiratory obstruction. A rare cause of goiter is biliary carcinoma of the thyroid gland, which can be part of multiple endocrine adenomatosis syndrome. We have multiple endocrine adenomatosis type 2 and multiple endocrine adenomatosis type 3. In the later, numerous small plexiform neurons form in oral mucosa, lip, eyelid, and skin. The patient may also have marfan habits and diarrhea. Other conditions called thyroid nodules. A nodule in the thyroid gland may represent a benign or malignant neoplasm. This figure shows solid echogenic hypoechoic thyroid nodule right in loops. We can see in the ultrasound that have a radiolucent. This is for thyroid nodules. Patients are examined with radioiodine thyroid scan and thyroid function test. A nodule that takes up radioiodine is termed hot nodule, unlikely to be malignant, and more usually an adenoma. A nodule that failed to take up radioiodine is termed cold nodule, and may be malignant, usually a papillary, follicular, or medullary cell carcinoma. Needle biopsy is indicated for thyroid gland. إذن عندنا حالتين أما gland call it cold nodule or hot nodule. The hot nodule that have a gland is active like in benign tumor, but in cold nodule that is not active like in malignant tumor. Now we start with the most important diseases that call it hyperthyroidism. This causes decrease in secretion of thyroid gland, and this hyperthyroidism caused by thyroid adenoma. So hyperfunctioning thyroid gland call it as a goiter. The hyperthyroidism is associated usually a diffuse goiter due to autoimmune disease like Levy's disease, primary hyperthyroidism. When there are thyroid-stimulating autoantibodies against thyroid-stimulating hormone receptor TRAB antibodies and thyroid microsomal antibodies. Sometimes with hyperfunctioning toxic multinodular goiter or nodule due to one of or more thyroid adenoma producing excess thyroxine. 90% of swelling are benign, rarely with thyroiditis, thyroid hormone overdosage, or ectopic thyroid tissue. The causes of hyperthyroidism. Most common causes like Levy's disease as autoimmune disease, toxic multinodular goiter, also known as toxic nodular stroma, independent or solitary toxic adenoma, thyroiditis, or inflammation of thyroid gland. But we have rare causes of hyperthyroidism like TSH secreting pituitary adenoma, stroma overall of or goiter of the ovary, predominance or entire presence of mass-charged thyroid cell in the ovary, metastatic differentiated thyroid cancer, metastatic tumor within thyroid gland. Clinical feature of hyperthyroidism. Acute emotion, particularly anger, fear, and anxiety, can cause greater rise in catecholamine output and transient rises in blood pressure, and should therefore be avoided or controlled. حقيقة patient عند hyperthyroidism يكون كلش حساس وعصبي من خلال زيادة الكاتيكولامين output. The hyperthyroidism mimics the effect of epinephrine and can cause anorexia, vomiting, diarrhea. weight loss, and anxiety, tremor, sweating, and heat intolerance, cardiac disturbance, particularly in older patients. These include tachycardia, dysrhythmia, especially atrial fibrillation, or cardiac failure, exothalamus, eyelid, leg, and eyelid retraction. Thyrotoxic periodic paralysis compressed attack of mild to severe weakness, during which serum potassium levels are generally low. Myasthenia gravis may occasionally be associated with hyperthyroidism. This table showing the clinical manifestation of hyperthyroidism. Sudden weight loss in spite of adequate or excessive food intake, tachycardia or increased heart rate more than 100 beats per minute, arrhythmia or irregular heart rate, bounding or racing heart beats, palpitation, increased appetite, insomnia or difficulty in falling asleep, enlarged thyroid gland visible at the base of the neck, nervousness, anxiety or panic attack, fine tremor or of the finger and hand, excessive sweating, irregular menstruation, heat intolerance, frequent bowel movement, eye fatigability, and muscle weakness. This figure shows the most important sign and symptom of the hyperthyroidism. This feature is very important for exothalamus of the eye. حقيقة جحوظ العين هي من أهم علامات الهايبرثايرويدزم بهذا المريض. بدون ما يتكلم تقدر عرفه أنه احتمالية كبيرة عند hyperthyroidism by exothalamus. How we can management of the hyperthyroidism. Start with the diagnosis. The specific antihypertensive therapy is urgently indicated where systolic pressure exceeds 200 millimeter mercury, or the diastolic exceeds 110 millimeter mercury, and may be indicated at lower level, particularly if there are vascular complications, diabetes, or end organ damage such as renal impairment. حقيقة في بداية الأمر يجب السيطرة على الضغط، تقليل الضغط إلى أقل من الشيء أكثر من الطبيعي، فيجب أن نعالجه باعتبار أنه يوجد أي مرض ثاني مع hypertension. The diagnosis of hyperthyroidism should be confirmed by raised serum level T3, T4, circulating TMA antibody and TR antibody in 50% of patients with Graves' disease, a radioactive iodine uptake test or thyroid scan. Radioactive iodine uptake can differentiate the cause of hyperthyroidism, subacute thyroiditis, low uptake versus Graves' disease, high uptake. The condition and the level of TSH, thyroid stimulating hormone, and T3, T4, T3, and other investigation to information to confirm the diagnosis. The Graves' disease, TSH low, high T3, T4, and can investigate the radioactive iodine uptake, increased uptake, thyroid pyridoxis antibodies is elevated, thyroid stimulating receptor antibodies is positive. Toxic thyroid adenoma, hot nodule, that TSH is again low, the T3, T4 high, that functional nodule superior, suppression of other tissue by radioactive iodine uptake. Toxic multinodular as again TSH low, T43 high, and by radioactive iodine uptake increase in large gland with multiple active nodules. And subacute or granulomatous thyroid and acetatus thyroxine induced thyrotoxicities and iodine induced hyperthyroidism that all low TSH and high T3, T4. This figure shows how the investigation by radioactive substance in normal condition and in case of Graves' disease, toxic malignancy or toxic benign tumor. Hyperthyroidism can be treated with Beta blocker. These achieve rapid control of many of the signs and symptoms, moderating sympathetic overactivity. However, suddenly stop beta blocker treatment can precipitate a thyroid crisis within 4 hours. The most important drug is carbimazole, the usual anti-thyroid drug, but it can suppress the bone marrow and rarely causes rashes. Nearly 50% of patients have a relapse. Propyltyrosine is an alternative to carbimazole. There appears to be no risk of neoplastic change. Surgery is effective but lead to hypothyroidism in about 30% of cases. Hypoparathyroidism or recurrent laryngeal nerve palsy are rare complications of surgery of thyroid gland. In untreated patients with hyperthyroidism, pain, anxiety, trauma, general anesthesia, or parameter causation of anti-thyroid treatment may precipitate a thyroid toxic, call it thyroid crisis or thyroid toxic. Thyroid crisis, or call it storm, characterized by anxiety, tremor, and dyspnea, is dangerous and can go into ventricular fibrillation. Medical assistance is essential as treatment requires the use of potassium iodide and propyltyrosine and propranolol or chlorpromazine. The treatment of hyperthyroidism, long-term or untreated subclinical or over hyperthyroidism, lead to risk factor, increased cardiac arrhythmia, increased oxygen consumption, increased heart rate, increased cardiac work, increased pulse pressure. This leads to increased left ventricular masses, impaired diastolic filling, increased arterial stiffness, increased arterial size, persistent atrial fibrillation, and pulmonary arterial hypertension. This leads to increased cardiovascular morbidity and mortality, lead to stroke, angina, myocardial infarction, heart failure, and sudden death. The differential diagnosis of thyroid trauma, hyperthyroid crisis, this differential diagnosis that have hypoglycemia, hypoxia, sepsis, encephalitis, meningitis, hypertension, encephalopathy, alcohol withdrawal, benzodiazepine, barbiturate, and etc. withdrawal, opioid withdrawal, and heat stroke that have a major differential diagnosis with hyperthyroidism. How we can manage patients have hyperthyroidism in dental clinic. Patients with untreated hyperthyroidism can be difficult to deal with as a result of heightened anxiety and irritability. The sympathetic overactivity may lead to fainting. Local anesthesia is the main means of pain control. The risk from epinephrine exacerbating sympathetic overactivity is only theoretical. Lidocaine with flipperosine is not known to be safer than lidocaine. Conscious sedation is frequently desirable to control excessive anxiety. Benzodiazepine may be initiated anti-thyroid drug and therefore nitrous oxide, which is more rapidly controlled, is probably safer. Povidone iodine and similar compounds are best avoided. Carbimazole occasionally causes granulocytosis, which may cause oral or oropharyngeal ulceration. Otherwise, the treated thyrotoxic patient present no special problem in dental treatment. However, after treatment of hyperthyroidism, the patient is at risk from hypothyroidism, which may pass unrecognized. This point must especially be borne in mind if a general anesthesia is required. This figure shows the most important feature of hyperthyroidism. The opposite to hyperthyroidism, we have discussed with you the hypothyroidism. The hyperthyroidism is etiological factor by two conditions, either primary or secondary. The primary due to the thyroid diseases is the thyroid gland itself that have the causes, and we have other causes for hypothyroidism fall secondary to hypothalamic or pituitary dysfunction. The most common cause of hypothyroidism are thyroid loss from surgical removal of too much thyroid tissue in a previous hyperthyroid patient, the destruction by irradiation of neck or thyroid gland, autoimmune disease like Hashimoto thyroiditis, and associated with autoantibodies to thyroglobulin and thyroid microsomes, drugs such as amiodarone, carbimazole, lithium, or radioiodine. Rare cases in the developed world are caused by iodine deficiency. The clinical feature of hypothyroidism, we have subclinical hypothyroidism with raised TSH but normal T4 level, may be found in up of 10% of post-menopausal females. Hypothyroidism is often acrogenized but can cause weight gain, lassitude, dry skin, myxedema, loss of hair, cardiac failure or ischemic heart disease, bradycardia, anemia, neurological or psychiatric change, hypotonia, cerebral sign of ataxia, tremor, and dysmenorrhea, polyneuropathy, cranial nerve deficit, intermittent neuropathy like carpal tunnel syndrome, myopathic weakness, dementia, apathy, mental dullness, irritability, sleepiness that have hoarseness, hypothyroidism, and may be complicated by coma. The Sjogren syndrome may be associated with congenital hypothyroidism, call it retinism, as a similar feature together with an enlarged tongue and learning impairment. This figure shows the most important sign and symptom of hyperthyroidism, easy to diagnose and treat if you think of it. We start with hair thinning, depression, schizophrenia, irritability, stomach of mind and body, big tongue, and weak heartbeat, foggy voice, dry skin, constipation, myxedema, cold skin, and high LDL, and slow reflex and cold intolerance. This figure again, you can see the most important feature of hypothyroidism. How we manage the hypothyroidism? First, the diagnosis of hyperthyroidism is confirmed by demonstrating serum T4 and T3 level low in hypothyroidism. The TSH level, the TSH immunohistochemical assay can discriminate directly between normal TSH and low level without requiring the use of thyrotropin-releasing hormone. Infusion test. Serum TSH is raised in primary hypothyroidism, depressed in secondary hypothyroidism. Serum antibodies in patients with Hashimoto thyroiditis, thyroid microsomal antibodies in 95%. Thyroglobulin antibodies in 60%. The symptomatic patients are managed with daily oral thyroxine sodium. Treatment is started slowly, but especially if there is evidence of ischemic heart disease, angina, myocardial infarction, or sudden death may be prescribed. Dental management for patients who have hypothyroidism. The main dangers of precipitating myxedema coma by the use of sedative, including diazepam or midazolam. Opioid analgesia, including codeine or tranquilizers. These should therefore be either avoided or given in low dose. Local anesthesia is satisfactory for pain control. Conscious sedation can be carried out within nitrous oxide and oxygen. Diazepam or midazolam may precipitate coma. General anesthesia may be complicated because of possible ischemic heart disease and other dangers of coma. And the respiratory center is also hypersensitivity to drugs such as opioid or sedative. General anesthesia, if unavoidable, should be delayed if possible until thyroxine has been started. Associated with problem may include hypoadenocorticism, anemia, hypotension, diminished cardiac output, and bradycardia. Occasionally, associations include hypopituitarism and other autoimmune disorders such as Sjogren syndrome. Povidone, iodine, and similar compounds are best avoided. We have Comparison between hyperthyroidism and hypothyroidism. We start with hyperthyroidism. The first is heat intolerance, excess sweating, warm moist skin, no hair loss, increased appetite, weight loss, tachycardia, atrial fibrillation, heart failure, no voice change, tremor, diarrhea, irritability, psychosis, atrial fibrillation, exophthalmos, and some amenorrhea and gynecomastia. Hypothyroidism is a main feature: cold intolerance, decreased sweating, dry, cold skin, hair loss, decreased appetite, weight gain, bradycardia, angina, and hoarseness, slow reaction, constipation, slow separation, or memory, psychosis, ischemic heart disease, periorbital edema, menorrhea, cirrhosis, and fusion. This figure shows the difference between hyperthyroidism and hypothyroidism. This figure for female, the difference between hyperthyroidism in red color and hypothyroidism in blue color. Thank you for your listening to this lecture. Any question later.